All right, so next up, we'll talk about edema. Edema is something that our patients are, in almost every single setting, our patients are going to be battling, and we're going to be able to treat them. So observable fluid accumulation, a little technical term, effusion is fluid within the joint capsule, and edema is fluid outside of the joint capsule. So who can think of that knee sprain where the leg just blew up, right? So that would be effusion versus grandma's legs with congestive heart failure, where there's just massive amount of water, and they take a step and it's just it looks like the cup in Jurassic Park, right? Edema can be pitting or non-pitting. We'll look at that in a second. There is a video, this video, Dr. Bob. I don't know who Dr. Bob is, but he's got a good explanation of edema if you wanted to spend some time with that. So first up, pitting edema is where we can press into our patient's swelling that they have, and that imprint stays. Anybody ever see that with, it usually happens with socks, really swollen legs, patient wears socks, and they've got that line of elastic just digs into them, and then you remove the sock and that line stays there. So that's pitting edema. So if you haven't seen it, I do have this video. I've been watching this video for a handful of years now, and the lady drives me nuts, but I do think it's a really good video.
Called pitting edema. So I'm going to show you. You can see the imprints where my shoes have been. I've just taken them off. And I want to show this to you. See them two little fingerprints. Those have been there for about 10 minutes. But they were deeper. So I'm going to show you here what happens. So pitting edema is edema that when you press on it like so, the pit stays there. Nice little set of fingerprints. And like I said.
All right, enough with her. What a humble brag. I've been traveling for several days. Like, all right, lady. Like, good for you. What's that? That's the kind of content some of us are looking. I guarantee Rex Ryan is one of those subscribers. Anyway. But that is a good video of what pitting edema is and looks like, because if you haven't seen it, it's kind of an abstract thing. So what we can do is we can assess pitting edema. What we're going to do is we're going to press our thumb into the patient's skin with moderate pressure. We're going to remove it and note the depth of indentation and how long it takes to rebound. Now, this scale that we're going to use here has just the depth to it. Some other scales that exist also talk about how much time it takes to rebound as well. But pitting edema scale 1+, the indentation is about 2 millimeters, 2+, 4 millimeters, 3+ is 6 millimeters, and then 4+ is 8 millimeters. So press in. What's the approximate depth that that indentation leaves, and then estimate it and grade from there. Other ways to measure is with a tape measure. So first thing we want to also note our patient's position. Why do you think position is so important when we're measuring swelling for this method? It'll change, right? So if we have swelling in our ankles, it's going to be different as we're standing versus supine versus leg elevated. So we want to note that because we want to be consistent with our position, because if we're measuring in different positions all the time, that's adding a variable that we don't want to. Because why do we measure anything? To monitor signs of progress. That's hopefully what we're going after. So the first thing we have to do is locate the most obvious bony landmark, because we want to make sure what we're going to do with the tape measure, we're going to measure the girth of the limb that's swollen. But I can't. You did bodybuilding? You did bodybuilding? Anybody else? You do any? When we're doing, you guys, you ever use tape measure for bodybuilding purposes? When have you done that? Measure the muscle growth and especially with bodybuilding, symmetry is really important. So right versus left sides. What's your technique for that? Have somebody else do it. But all right, so you're gonna do it to somebody else. What's your technique? Yeah, and I think in general, it's going to the widest part of the muscle. So the peak of the biceps is where you'd like to measure it around. All right, but so that's okay when we want just girth of a muscle, like is this muscle bigger than the other side? But when we measure girth for edema, we want to be a little bit more precise with that because it's going to change a little bit. If I've got a lot of knee swelling, that knee sprain, as I walk around, it's going to shift around a little bit. Gravity's going to pull it down. We need to be able to capture that. So the minimum is at least 3 different locations on the area that you see is swollen. You can always do more. As a clinician, you can always say, you know what, 3 is not quite enough. I'm going to do more today. And that's okay for you to do if the therapist selected girth measurement on day 1 and only did 3. And the next time they come in to see you, if you say like, geez, this swelling is all the way down to the ankle today, I'm going to do a few more. That is okay. That's perfectly acceptable for you to do. But we want to be specific with our exact spots. So we're going to get the first most obvious bony landmark available. So if it's the lower extremity, what are the obvious bony landmarks? I think the malleoli are the easiest ones. How about Cankles McGee over on the video that we just saw? Does she? How are her? Is that her YouTube handle, Cankles McGee? Do you think it's easy to find that woman's malleoli? No, it's buried in a bunch of pitting edema. I don't know exactly where that is. So what's the next most common bony landmark you might use for that woman? Maybe the calcaneus. Good. Anything else? Navicular? I'm not so sure about that. Any other most obvious? I heard tibia. Tibial tuberosity. I think tibial tuberosity is probably a perfect one for this woman. So yeah, the most obvious one. What do you guys think about the patella as a landmark?
I mean, you can, depending on how large, I guess, well it is, but we're talking about the ankle, right?
So I don't think there's a big problem with distance away, although it's a factor. The big problem I have with patella is they're floating bones. So especially when we consider swelling, they can change in positions one day versus the next. And what do we think right patella versus left patella? If our goal is to get a right versus left comparison, does everybody's patellas line up exactly the same on right versus left? So I don't use patella because it's a floating bone and I'm not sure it's going to be the best spot. I like a more rigid thing than that. But for me, tibial tuberosity and malleoli are the big ones of the lower extremity. Upper extremity, what do you think?
Oh, olecranon probably.
I think olecranon is a great one. Any others? Be more specific. Yep. I've got a different method. I wouldn't use tape measure for that. We've got a different tool we can use for that. Styloid processes, I think, are probably the next most common ones. Probably the ulnar ones are the more easy for that. So medial and lateral epicondyles, maybe if they're prominent. I think for you, that's tough to find those. But your olecranon, I can see it from here, you know? So yeah, but here's the thing. It's got to make sense to the patient. What's the most obvious bony landmark you could pick from? That's what your first step is. Your next step is we got to figure out the 3 measurements to do that. So here's my tip for that. Could I steal your forearm? So Addie has some swelling. Let's give him some swelling. let's say he was hit by a softball, right? He went to go catch it, he missed it, softball creamed into his forearm there. He's got a big pocket of swelling right there. I've got to measure that swelling. So I need a minimum of 3 locations to do it. I can easily go more if I think I need to. And what I'd like to do is measure somewhere close to where the swelling starts, somewhere midpoint of the area of swelling, and then somewhere towards where it ends. So somewhere proximal, middle, and somewhere distal. So I'm going to find, if we thought his styloid process, radial styloid is pretty prominent right there. I'm going to take that and I'm going to lay my tape measure down his arm. Now, looking at him here, I'm going to say, okay, 9 centimeters is the most distal. 15 is right in the middle. And then I'm going to go 20 for my most proximal measure. Now, I don't have, if you got hit by a softball in the same area, my exact locations on you would be different. I'm just using my best clinical judgment for I think I need to measure. All right, so once I mark him, now I'm going to take my measurement and I'm going to encircle him at those landmarks. At 9 centimeters proximal to radial styloid, I've got 21 centimeters. At 15 centimeters proximal to the radial styloid, I've got 27.3 centimeters. And my most proximal landmark, I've got 28.4. Then I get to jot all that down. I compare it to the other side. The other side, I get the exact same thing. So the other side, if I wanted to, I would measure from the radial styloid. I mark 9 centimeters, 15, and what I say, 20, because I want to get the exact same locations that I did on the other side. I can't just blindly throw my tape measure on him, because especially if you look at Addie's and any of our forearms, the amount of taper they are, I mean, they taper quickly. Same thing with calf. So if I'm just a little bit off, that's going to throw my comparison numbers off really quickly. Okay, does that make sense? So what I'd like to do is let's do an upper and a lower practice rep of these. Now, the amount of tension you want on these is we don't want to indent the skin when we encircle our patients. There are some tape measures. Ooh, I don't have any here. When you guys were doing bodybuilder, do you guys have the I think they're called the Gyrick tape measures? They have a little plunger with a little spring into it. So some of those, it has this little plunger and with a little etching on it where it just helps you have the same amount of tension each time. That's a pretty cool one. I'll try to find one, but let's take a minute, practice an upper and a lower reps of both sides. So this is going to take us a little bit of time, okay? I'm not sure. Can you show me what you mean? Oh, I would try to be as accurate as I can. If I thought it was going to be a major source of measurement error, I would like to fix that. Yeah, I wouldn't consider that a major source of error. But I think on some people it could. Some people's calves are really taper a lot, and that could be it. Yeah. Yep. All right. Any other questions about it? All right. Who's got a foot I can steal? Who was it that liked speed over here? Was it you again? I got it. Who's got one? Yeah, perfect. Thank you. All right, pop the shoes off, please. Let's sit right up here. All right, so I will show you the figure 8 method, which I'd like you to try as well. Figure 8 method is really good for the ankle. Good, sit all the way up there. And you can, your feet can be dangling over here. Good. All right, so the figure eight method, I'm going to start my zero right in between the two malleoli on the front of the foot. And then I'm going to make a figure eight. I'm going to loop down, around, back, and then come back to my starting point here. And there's my figure eight method for if it's like that big ankle sprain, who's gotten those big ankle sprains, the whole ankle's puffed up. So that's my figure eight method. I'll show it one more time. So put my zero right in between the two malleoli, right on the front of the foot. I'm going to come down, around, and then back there. Okay. It doesn't matter if you start your figure eight towards the medial aspect of the foot or the lateral aspect. The number should come out the same no matter what. I would like to be consistent. That's just one of my things about measurements. Like if I'm going to dive to the medial aspect of the foot on this side, I'd like to do the medial aspect of the foot on that side. I don't think it's going to be a huge source of error, but I like to eliminate any source of error possibly. So let's try the figure eight method as well. Okay. Thank you, Rachel. About that. Yeah. Before we go to the other room to do the volume meter, I just want to point out that we could use these girth measurements for muscle size. So we talked about it just briefly with bodybuilding, but if my patient's biggest problem isn't swelling, but it is muscle atrophy after ACL repair, knee replacement, those are the big ones I can think of. I can use girth measurements as a sign of progress and be able to say to the insurance company, no, it doesn't matter that they can walk, they can't return to sport because their muscle mass is so diminished versus the other side. So that is something that we could do. And documentation wise, I'm a big fan of charts and tables because it makes it easy to read. Tell me which is the bigger side, left or right on this example. It's hard to see, right? But if it was in a table, right side, left side, exact locations, and you add in the numbers, man, you'd be able to see that right away. So there are still clinics that do handwritten notes, and I will tell you, the more organized the notes are, the easier they are to read, and especially when you've got between 16 and 30 patients in the day. If I save an extra 10 seconds per note that I read, it adds up. It definitely adds up. Yep. Yep. Something else I was going to say, but it escaped me. So the next thing we'll look at is volume meter. So the volume meter is we're going to use water to measure and displaced water. So let's go into the other room, and I've got everything set up in there. I'm going to stop sharing so we can see this a little bit better. So next up, we're going to use water displaced as our measurement of volume, right? So how much swelling is there? There's a big volume size left to right. One side is a lot bigger than the other. Now, you talked about hands and fingers being the problem. So the problem with using tape measures, first of all, my rules of measurement with a tape measure for girth are what? I need how many measures? So if I've got two fingers that are really swollen, I need 3 measurements of each finger. There's just not a lot of space. It's irregular. So we get to use the water displacement for hands and feet. Over those 2 stations are feet. The procedure is the same, just the anatomy is different. Now, the first thing we have to do is protect the area, right? So we just learned about incidents, emergencies. Having a wet floor is a risk of injury. So if I dropped any water, if anybody else did, make sure we clean it up right away because I don't want anybody to fall. The other thing we've got to do is we've got to make sure that our patients have equal hands. So any jewelry that I've got on one hand versus the other, we've got to take off. So if I'm doing the volume meter or going out to the bar, I take out my wedding ring. And then I have to, the next step, Dion turned away from me. He was so disgusted. That's how good of a guy Dion is. He goes, that is such a awful joke. I'm not even gonna look at you. That's a guy that you want to respect right there. I'm not even gonna laugh at that joke. I'm such a dedicated person. I'm not even gonna laugh at that. All right, so the next step is I've got to fill this to the top. I know it's at the top when water trickles out. So I'm going to put this here to catch excess water. I'm going to fill this up to the top as soon as it starts dripping. Then I just got to catch that, wait for it. This is the kind of pain part, is we have to wait a while. But once it stops dripping, then I'm good to go. I dump that water in here because I don't want it staying in here because I need to use this. All right, next up, if you can see, there's a little plastic bar in the middle there. What we want is we want our patient's anatomy to rest on the bar. I will see if I can find in the textbook. I have two different textbooks. One says the web space in between the first and second finger. I have another textbook says between third and fourth. So I've gotten the habit of going into third and fourth. So let's make that as our standard right in the middle there. Okay. So I align this. I instruct my patient, okay, you're going to put your hand in. That bar is going to fit right on. I want it to touch that web space. And then we're going to wait till the water stops trickling out. And then you get to dry off. Can you throw me a towel? Any towel. Perfect. All right. So we dunk the hand in, catch the water. Once it stops dripping, you give the patient a towel, then we place this on the table and read it. What mistake did you see that you might have been? Some dripped out, right? So what should I do? Redo it, right? So that little bit of error could be enough. So I should redo that one. So telling your patients to go slow. This one that's got kind of like a trough exit versus those which has a cylinder. These have a tendency to spill just a little bit more frequently in my experience. So the foot ones are the exact same thing, except it's down on the ground. Okay. All right. Any questions on that? All right. So we've got 4 hands and 2 feet. Let's do it real quick. Just everybody wash their hands since we're going to reuse this water a bunch. So everybody sanitize or wash their hands, and then we'll play with this stuff, okay? All right, so again, the big mistakes with the volume meter, not filling it up to the top in the first place, not removing jewelry from the patient, and then forgetting some sort of error with catching the water displaced. They're the big 3 errors with that one. All right, so we'll quickly go into lymphedema. Now, I will say lymphedema is a huge topic and one of those specialty practices in physical therapy that if you wanted to become a lymphedema specialist, you usually could. And especially as a PTA, there's some roles for that. And the most common mechanism of lymphedema is post breast cancer. Because the cancer, where's the biggest area of lymph nodes? Axilla and then groin. So when cancer is near those 2 areas, it's really easy to have cancer spread. And they often take lymph nodes to biopsy. That removal of all lymph node impairs the lymph system. So the lymph system is a one-way drainage system designed to rid tissues of unwanted material and mostly excess fluid. Lymphedema is an overload of the lymph system. So it's not curable, but it can be managed. So indications, primary, secondary lymphedema, trauma or radiation after a burn, after an obstruction resulting from a tumor scar, inflammation, parasite, idiopathic. What's idiopathic mean? I don't know. No, really, that's what it means. We don't know. Idiopathic means we don't know why it started. Post-operative edema, venous arterial insufficiency, scar management. So contraindications, acute infection. Patient has to be able to be taking antibiotics for at least 4 days prior to treatment. Active cancer, congestive heart failure, or kidney failure, and after radiation. So there's a huge risk of skin breakdown, and once there is skin breakdown, there's huge risk of infection for people with lymphedema. So avoiding extreme temperatures, another thing that we have to think about today. Avoiding factors that cause infections like bug bites, pet scratches, avoiding blunt trauma, avoid use of alcohol and nicotine, wearing compression garments and elevate the limb when traveling by air. Maintain nutrition and hydration, maintain body weight to avoid obesity, meticulous with skin and nail care. We talked about that a little bit with more of the lower extremities now, but now upper extremities. Exercising daily and hypoallergenic soaps and fragrances. So management can include, it's called CDT, either complete or complex. It's used interchangeably. Decongestive therapy. So the goals are to enhance lymph drainage with manual techniques, control edema with compression bandaging, use of intermittent pneumatic compression devices. We have one. When Tony's here, we'll break it out and demonstrate what that looks like. Reduce or eliminate infection, obviously protecting the skin. Gentle exercise to enhance the lymph flow and educate the patients how to manage their symptoms independently. So this CDT can range anywhere from 2 to 8 weeks, 3 to 5 days a week, depending on severity. Once it is complete, the patient can be fitted for a custom compression garment. I don't know if anybody's seen those typically it's all arm sleeves. Again, the number one common area of mechanism of lymphedema is post-breast cancer. So superficial massage is extremely gentle. I think next semester we talk about the amount of pressure that it takes, and it is, I think, I could be wrong on this. This is off the top of my head. I think it's the weight of a quarter is the amount of force that you want to place into the person's skin to promote lymph drainage, because these lymph vessels are really, really sensitive. They're really weak. So too much pressure can just obstruct them. Well, now we're not promoting fluid movement. So it's really, really light pressure. It almost feels like you're like, I should be doing more here, but it's super, super light. Now, intermittent compression. So this is something we do have to know of. Again, it's going to show up on the next exam. It's going to show up on the licensure exam as well. So it is, let's see if we can find a quick picture of it, just so you know what we're talking about. There's a happy guy with one of these. So here's the upper extremity version 1. What do you guys think about patient position? Like, I think we can fix this a little bit, but okay, it's fine for a picture. And all it is there are different chambers in this big sleeve, and this chamber will squeeze, and then this chamber will squeeze, and then this chamber will squeeze, and then this chamber will squeeze to try to progressively move that fluid proximal. So that's pretty fun. We'll have a demonstration of that. I'm seeing this more and more used with athletes. You guys see it more with restorative athletes? Anybody ever play with one? Any clinic have one? You've played with it though? You've used one? What do you think? Give me some. Well, I've got news for you about modalities. None of them actually do what they say they're going to do, but they're fun and the patients like them, so we're going to do them. Now, I will say, I mean, I'm hypercritical about, you'll hear this every single day next semester. I'm hypercritical about all modalities. But for someone who has lymphedema, we do everything we possibly can to get rid of it. And so. So indications, chronic or post-traumatic edema, variety of pumps, cost ranging from a few $100 to several thousand. Multi-chamber pumps inflate sequentially, like we just talked about. Guidelines for the pressures of the pump. In the textbooks that we have that are assigned to you, there is a conflicting advice. So I will clarify what it is, but that's why everything's highlighted in yellow. On page 315, it says pressure should be above diastolic, but below systolic. On the next page, 316, it says not above diastolic. So that's a nice little typo for us, right? So inflection pressures can range from 30 millimeters of mercury up to 80 millimeters of mercury or below the patient's diastolic. Lower pressures are generally used for upper extremities. So we'll clarify exactly what it is next for us. Contraindications, patient cleared for ulcers, arterial insufficiency, thrombophlebitis. What's that? Blood clots, good. Cancer in the area, heart failure. Why heart failure? You guys know? Would you guys know what heart failure is? Congestive heart failure. Congestive heart failure is just the heart is not pumping efficiently and it's not moving the fluid appropriately. What we wouldn't want to do is force a lot of fluid to the heart because the heart can't pump excess fluid as it already is. So that's really tough if you have lymphedema and congestive heart failure. I don't know what you do. The same thing we do with the people with MMT scores of 0. We hand them to the card of the place down the street and say, I think they're great. Anyway. And do not use with patients of high blood pressure or initial blood pressure readings of 140/90. So we have to test their blood pressure first. So the limb should be at the level of the heart or higher. Little flaw with that seated position. Treatment time could be as little as 30 minutes. Extreme times up to 6 hours a day. So I think patient position really matters. I mean, even 30 minutes. Anybody want to hold their arm without that sleeve and all the tubes attached to it for 30 minutes just like this? No. So we've really got to pay attention. Frequency anywhere between 3 and 4 times a week. Stop if the patient complains of pain, numbness, or tingling. So procedure. Patient should be comfortable. That patient position is really, really important. Remove all jewelry. Take and record girth measurements. Now, there are some things in physical therapy, and it's not all the time. So when it does happen, we should capitalize on it. If we can measure a problem, apply a treatment, and then immediately remeasure that problem, man, that is really good. Most of the interventions we give take 3 to 8 weeks for progress. But this, if we've got a lot of edema and we use this intermittent pneumatic compression, we can get a change in 30 minutes. That's really fun. Apply the stockinette, then compression sleeve, take the blood pressure, determine blood pressure setting. So machine on adjust the pressure. So the lowest setting to be effective is 30 millimeters of mercury. The highest setting, we're going to use the patient's diastolic blood pressure. So that is the safe range. At least 30 to be effective, no higher than their current diastolic. And then exactly what you do depends on the patient's comfort from there. As we're pumping up blood pressures, if you could think of, what do you guys think as we're pumping up, inflating the cuffs, and when we're getting in them 40 to 50 millimeters of mercury, how does that cuff tightness feel? Anybody feel uncomfortable with that amount? So if that's the case, I mean, this is going to be a long time for our patients, 30 minutes to 6 hours. So it has to be within patients' tolerance or else it's ultimately going to be ineffective. So anywhere between 30 and the diastolic blood pressure is the range. Exactly what is exactly like how we do our stretching techniques. Can I go for, how does that feel? Can I go any further? Can I go any further? Can I go any further? Oh, no, I have to stop. That's your diastolic blood pressure today. And then after we get to remeasure the girth again. So we could also apply compression bandaging, which follows manual lymph drainage and pneumatic compression. These are very similar to, and don't let the decongestive therapists in the world know that I said this, because I'm sure it's very wrong what I'm about to say, but it's very similar technique and material that we use to wrap our legs when we did our wound care, right? There's a technique to crossing it to make sure there's an even pressure gradient. The material is a stretch